Good day, everybody. This week, we start on meds that affect the autonomic and central nervous systems. But first, a very quick review. So let's move on to the next slide. The nervous system is composed of the central nervous system, made up of the brain and spinal cord, and the peripheral nervous system, which contains nerves that carry information to and from the central nervous system. Neurons are the structural units of the nervous system. These units have dendrites at one end that receive information from other neurons. The information travels through an elongated area of the cell called an axon. This information is transmitted as an electrical impulse, and that's called an action potential. The action potential reaches the end of one nerve, known as a synapse. When the action potential reaches the synapse, a chemical is then released called a neurotransmitter. The neurotransmitter will carry the information along the synaptic cleft to a receptor site on another cell. This in turn causes a change in the functioning of the postsynaptic cell, that new cell. Neurotransmitters can either excite postsynaptic cells or inhibit them. We'll move on to the next slide, because that will bring us to the autonomic nervous system, the ANS. The ANS works with both the central and peripheral nervous systems, as well as the endocrine system, to maintain homeostasis, the steady state in our internal environments. The ANS is made up of the sympathetic nervous system, that fight or flight response that helps us prepare for stress, as well as the parasympathetic nervous system, the rest and digest response. The rest and digest response allows us to conserve energy. These two systems work together to provide balance. We'll look up here to the sympathetic nervous system first. An impulse starts here in the spinal cord and travels along a neuron until it reaches the first synaptic cleft. Acetylcholine is released, and this neurotransmitter carries the message chemically across the cleft until it's received by a cholinergic receptor known as the nicotinic receptor. The impulse continues to travel along until it reaches still another cleft. But this time, it's norepinephrine or epinephrine that carries the information to another receptor. This receptor is known as an adrenergic receptor. These adrenergic receptors are found throughout the body, and once they are activated, will result in those signs of a stress response that you've studied ever since Nursing 1. Adrenergic receptors, noticed here, can be classified as either alpha or beta, and they can be further subdivided into alpha 1, alpha 2, beta 1, and beta 2 receptors. Alpha receptors can be found in nerves, blood vessels, the iris, and the bladder. Beta receptors are located in the heart, lungs, blood vessels, and liver. Medications that activate adrenergic receptor sites are called agonists. Medications that inhibit adrenergic receptor sites are antagonists or blockers. And now we'll move on to slide 4. Adrenergic agonist medications interact with adrenergic receptor sites and produce a fight or flight effect. This class of medications would include catecholamines like norepinephrine, and non-catecholamines, like ephedrine. Norepinephrine and ephedrine tend to be the least selective of adrenergic agonists, and they activate both alpha and beta receptors. Move on to the next slide and talk about norepinephrine. Norepinephrine is a catecholamine that's converted from dopamine. An action potential is going to cause its release. The norepinephrine travels across the synaptic cleft to either an alpha or beta receptors, or both. Norepinephrine will return to the presynaptic cell, or it'll be destroyed by monoamine oxidase, MAO. Norepinephrine tends not to last very long. It's either reuptaked or destroyed in order to maintain some balance. Norepinephrine is used for the treatment of shock in order to increase blood pressure, and it's also used for cardiac arrest. Epinephrine is non-selective and will bind to beta 1 and beta 2. When it binds to beta 2 receptor sites in the airways, epinephrine will relieve that bronchospasm that accompanies anaphylaxis. Epinephrine will also cause an increase in blood pressure and heart contractility, so it's used for the treatment of shock. Now, time out here, ask a couple of questions, and I'm going to check with your answers when we return to class next Tuesday. A client is receiving IV epinephrine and complains of pain at the IV site. Why is it essential to stop the IV? Next question. Your client is receiving an IV sympathomimetic. Sympathomimetic is the term we use for medications that mimic the sympathetic nervous system response. So if your client is receiving an IV sympathomimetic for shock, how do you assess its effectiveness? What changes in vital signs might you see? Now it's time to move on to the next slide. When adrenergic agonists like epinephrine is injected along with a local anesthetic, it's going to cause vasoconstriction, and that allows the local anesthetic to remain at the site for a longer period. In other words, epinephrine will prolong the effect of an anesthetic like lidocaine. In addition, epinephrine will often raise blood pressure when other medications fail, and it has a sympathetic effect on pupils, so it will cause pupil dilation. Some of the side effects include severe hypertension whenever it's administered parenterally, can also cause bradycardia, and when epinephrine is given IV and it leaks into tissue, it can cause tissue necrosis from the severe vasoconstriction that occurs. Also, hypokalemia can occur from the release of aldosterone. Remember that renin-angiotensin-aldosterone system is activated when sympathetic nervous system activation occurs. The result of that is that the body rids itself of potassium, thereby causing hypokalemia. Some extra information on alpha adrenergic agonists. Phenylephrine is an alpha agonist used in the treatment of shock. It's also used as a nasal spray. You might have heard of this medication, neosynephrine. Neosynephrine causes vasoconstriction in the nasal passages, and that helps to relieve the swelling that comes from nasal congestion that accompanies upper respiratory infections. Alpha-2 adrenergic agonists have little effect on peripheral region, but activation of alpha-2 receptors in the central nervous system sometimes cause a sharp drop in blood pressure. Now, one of the categories of medications that don't quite fit into the other categories that we're discussing today are the indirect acting anti-adrenergic agents, most notably clonidine. Clonidine suppresses the firing of sympathetic nervous system nerves, and that will decrease the release of norepinephrine. All right, so clonidine suppresses firing of sympathetic nervous system nerves to the heart, and that will reduce blood pressure, heart rate, and cardiac output. It has other uses as well, like treatment of pain, clients with cancer. It also decreases the adrenergic effects of opioid withdrawal. Because clonidine affects the central nervous system, there are side effects possible like nightmares, sedation, and headache. It can also cause hypotension and heart failure. It's important with clonidine to remember not to stop it abruptly. On to the next slide. We'll talk about beta-1 agonists. Epinephrine is often used when other procedures have failed. It's not the preferred treatment for cardiac arrest because epinephrine can increase heart rate and force of contractions in clients with shock. However, it can also cause tachycardia, dysrhythmias, and angina. And in fact, it can increase oxygen demands of the heart and worsen cardiac conditions. It's sometimes used as a temporary treatment for atrioventricular block, where there is either diminished or no conduction between the atria and the ventricles. However, the preferred long-term treatment for AV block is a pacemaker. So this is just a temporary solution. Now we'll move on. We'll talk about beta-2 agonists. Beta-2 agonists are used to target cells in the lungs and uterus. When beta-2 receptors are activated in the airways, bronchodilation occurs. Although inhaled, beta-2 agonists don't absorb that well into the bloodstream, there is some potential for the beta-2 receptors in other organ systems to be affected. Activation of beta-2 receptors in the heart, for example, could cause tachycardia and palpitations. Because activation of beta-2 receptors in the liver will convert glycogen into glucose, serum glucose levels can increase. So we've got to be cautious for those clients with diabetes. Clients with diabetes who are prescribed beta-2 agonists might need an increase in their insulin dosage. Now, another type of beta-2 agonist would be terbutaline. Terbutaline is a beta-2 agonist available in PO. When terbutaline binds to beta-2 receptors in the uterus, smooth muscle relaxes, contractions decrease, and preterm labor is delayed. Just a quick word about albuterol. Albuterol is the medication of choice for an acute asthmatic attack. It's a rescue medication. Albuterol, when it acts on beta-2 receptors in the lungs, relaxes the smooth muscles, causes bronchodilation. However, it can cause an increase in cardiac, CNS activity, or diuresis. Don't use if the client is experiencing tachycardia, heart block, or cardiac disease. It is used for reversible airway obstruction, prevention of exercise-induced asthma, and emphysema. There are other medications that are used for the prevention of asthma attacks as well, and we're going to discuss these in week 11. And that brings us to adrenergic antagonists. If adrenergic agonists have a sympathomimetic effect, they mimic the sympathetic nervous system response, then adrenergic antagonists have a sympatholytic response. In other words, adrenergic antagonists have a parasympathetic-like response, so they can be used to counteract the effects of medications like epinephrine. They can also be used for treatment of hypertension and benign prostatic hyperplasia. A few words about the alpha-1 antagonists, the alpha-1 blocking agents. They are contraindicated when there is a known hypersensitivity or if the client is breastfeeding. There are also adverse effects on the fetus. This class of medication should also be used cautiously in clients that have heart failure because the condition could be exacerbated. Alpha-1 blocking agents cause vasodilation in arterioles and veins that decreases the return of blood to the heart and gives the heart a little break by decreasing cardiac output. I mentioned before that epinephrine, when it leaks into tissues around an IV site, can cause necrosis because of the severe vasoconstriction. Alpha-1 blocking agents are often given in order to counteract that vasoconstriction that occurs in tissues, thereby preventing necrosis. Alpha-1 blocking agents are also used for the treatment of benign prostatic hyperplasia, the hypertension that occurs with pheochromocytoma, and to treat symptoms of Raynaud's disease. And we'll move on. Talk a little bit about the adverse effects of alpha-1 blockers. These would include dizziness, syncope, orthostatic hypotension. Blood tends to pool in veins with these medications, so that when the client stands quickly, there'll be decreased blood flow to the heart and the head. Now, because blood pressure is reduced through vasodilation, the heart rate might increase in order to compensate. Also, some medications, like tamsulosin, can result in ejaculation impairment. It's important to communicate to the patient that this ejaculation impairment is reversible and that the problems can subside when the medication is stopped. The patient can be switched to a different medication. Tamsulosin is an alpha-1A blocking agent, so its action is much more selective. It binds to alpha-1A receptors in the prostate, used in the treatment of BPH. And when it binds to the alpha-1A receptor sites, then smooth muscle relaxes. In addition, alpha-1A receptors in the bladder and urethra will relax, and that allows for better urine flow in clients with BPH. Important. Teach your client, don't drive for 4 hours after the first dose because of the hypotensive effects of the medication. And now, the beta blockers, which can be non-selective or selective. Remember that the non-selective beta blockers would tend to have more side effects since they will bind to receptor sites in areas other than just the target cells. Beta blockers are used for multiple reasons, like angina, when the client is experiencing chest pain and oxygen supply doesn't meet oxygen demands. When we block beta-1 receptors, cardiac demands decrease. They're used for treatment of hypertension because peripheral vascular resistance is reduced when we block beta-1 receptors. Dysrhythmias are treated with beta-1 blockers. We suppress the conduction between the atria and ventricles. We prevent the ventricles from pumping at an excessive rate and allow the atria and ventricles to work together in a more coordinated fashion. Finally, beta-1 blockers are used in the treatment of myocardial infarction because, as mentioned before, it decreases O2 demands. And we will move on and talk about some of the adverse effects of beta-1 blockers. These would include bradycardia, decreased cardiac output, heart failure, and AV heart block, beta-2 blockers can cause bronchoconstriction. So clients that are asthmatic and are taking a beta-2 agonist should not take a beta-2 blocker, because a beta-2 blocker will counteract the effects of albuterol. Instead, asthmatics should use a beta-1 blocker like metoprolol. Remember also that beta-2 blockers can cause hypoglycemia in diabetics because they interfere with the transfer of glycogen to glucose. And that makes the medication of choice for asthmatics and diabetics metoprolol, Lopressor. It's selective, it blocks beta-1 receptor sites, and the effect is to lower blood pressure and heart rate. And this ends my lecture on adrenergic agonists and antagonists. Thank you.